Now, explosion of technological advancement in dentistry and surgery as a whole has increased the challenge of the dentist restoring patients with tooth or teeth loss to full stomatognatic health and function, as the traditional or conventional treatment are no longer satisfactory to patients. The patients are not interested in dentures anymore. And if they take denture from you, because they cannot afford crown and bridge or implants. Although dental implantology now continues to be the choice of replacement, we must remember that patients do not want implant. They want teeth. So what that statement means basically is that the patients, they really don't appreciate the implant surgery you did. Huh? So all those patients are not interested in the surgery I did yesterday. They are interested in what is to come, the restoration. So that if you are not thinking about the restoration from day one, then there is a problem. So you should be thinking about the restoration from day one. Interdisciplinary approach to surgical and restorative aspects of dental implant therapy continues to be the main success for patient satisfaction. And basically, if it's an environment where, yes, you have an hygienist, yes, your hygienist prepares the patients in terms of oral hygiene prior and post implant treatment. If you have a restorative person or specialist who will be restoring the implant eventually, you need to consult with that person. You need to consult with a lab technician and so on and so forth. If you have to do maxillary sinus lift and you're not comfortable with that procedure, then you need to consult with the oral surgeon and so on and so forth. Now, I can assure you that no simple implant really exists. There is no simple implant procedure. All of them are technical. All of them have a lot to go into it to make the procedure a success. And as such, the evaluation, the diagnosis, and the treatment planning must be complex and comprehensive. And the following complex and comprehensive approach should be approached or should be utilized. Now, the first thing is initial consultation. And let me tell you, all my patients for implant treatment, initial consultation is free. No matter how long I spend with them, initial consultation is free. And I try to spend at least 1-2 hours with them. I probably do it on a public holiday, on an evening, or a Sunday, something, when I have time, so that I can explain a lot of things to them. Now, you must evaluate the patient's past medical history, which should include history of illness, hospital admission, past surgical history, including nature of surgery and any other complications. Now, during this phase, you are able to determine if this patient is medically fit for the procedure. Does the patient have any bleeding disorder? Right? Now, allergies to medication and the nature of the reaction of the allergy is not just telling you, yes, I'm allergic to this. What is the nature of the reaction to the medication? And you must find out the name of the medication and the dose of the medication. You must take family history and social history, and this should include history of cigarette smoking, alcohol consumption, the use of drug, and the risk of HIV or the or other habits that may pose a patient to having HIV. You must review the system, and this must include recent changes in well-being as well as specific status of organ function. And you must ask patients directly questions. Do you have any psychiatric problem? And a lot of dentists find it very difficult to ask the patient if they have psychiatric problem. But I ask them, once my patient sits on the chair, I have a list of, I say, do you have any psychiatric problem? And they tell me. Because, you see, they're shocked when you ask them, huh? Some are shocked and some are happy that you are taking it into consideration. And the truth is, the reaction is, they just tell you, yes or no. And it's straightforward like that. Now, dental history, you must, documentation should include past dental history, the nature of the treatment that was done, and radiographs that were taken. You must ask them about the complications and the problems regarding the previous dental treatment. And also, you must ask about parafunction. And I'm telling you, I had a case just after the hurricane in Cayman and in Grenada. Very lovely lady. And, you know, when I examined her initially, there was no evidence of bruxism. But after the hurricane in Grenada, you see, her house that they built was uprooted by a hurricane. They lost everything. Everything was lost. Do you understand what I'm saying to you? Everything was lost. And basically, from that time on, that patient began to bruise. I mean, a week after the hurricane, she still flew down to Jamaica, had her implants done, and it was restored. It was restored, and eventually, a year or two after, mobility setting. And I'm saying to myself, I did this implant, I know I did everything all right. Why is this happening to me? You know? And by the time I checked her mouth, you could see that severe attrition in the lower. So she said to me, yes, doc, since the hurricane, I've been grinding in the night. They lost everything. So that I had to redo her implants for her at no cost. And the redoing of the implant cost me a lot of money because I had to do it in an operating theater. I had to bone graft. And then we did the restoration. In fact, to maintain a good length of the implant in the anterior region, I had to do a subnasal augmentation. So you must find out history of any cephalic episode or TMJ arthropathy. You see, head and neck pain is a very complex thing, okay? And head and neck pain can lead you to a lot of things in the management of a patient with cephalic issues. And there is a questionnaire, and I hope I can get out questionnaires for you to take with you that you can actually use to educate your patient and to find out information from your patient. Now, dental hygiene status is also mandatory. Implant failure with spontaneous rapid exfoliation is an issue. Now, one of the things that you want to do is find out if the patient has had implant treatment before. And if the patient has had implant treatment before and it has failed, you must find out why did it fail? What were the circumstances behind the failure? Now, the psychological profile of the patient must be assessed by the clinician during the initial consultation. This is mandatory. The level of anxiety should be assessed, and at this stage, you will be able to determine whether you are going to do the procedure under local and sedation, or under GA. And all this will create an insight on what is important to the patient. You need to appreciate the patient's expectation so that there is a trusting doctor-patient relationship. And of course, I have patients who will come to me and they will say to me, Doc, you see this picture of this artist in America? Look at her smile. That is how I want my smile to be. Now, those are serious patients. For them to cut it from the newspaper and bring it to you and say that is how they want to look. So those patients, you need to spend some time with them, that there's really no mouth that look the same. And that, you can't, but you will make them look like themselves. Something that is going to be looking nice, So you can't promise them anything that you can't give them. And sometimes patients will ask you for ridiculous appearance. I had a patient who once asked me that, we did the restoration, but then she started to draw for me how she wanted to look. Now, she drew the central and she measured the dimension. It was very big. That's how she wanted her central. And then she wanted her lateral very big, and so on and so forth. And I told her I couldn't. She became very emotional. She was crying. So I still have the restorative job here. So I had to say to her, I'm sorry, I can't do it for you. And she had some of my money. I had half of the job, but she just disappeared. And this has been like about 8 years now. She was crying. She came to me on several occasions to see if she can make me tell the lab to make the teeth that big. I said, I can't. Now, in summary, the initial consultation appointment allows for the completion and review of an appropriate medical history questionnaire, the completion of an appropriate dental questionnaire, and the preliminary evaluation of patient's emotional and psychological profile, which would include treatment, expectation, and desire. And if I had taken a lot of time, I would have actually realized that that patient had a psychological problem. She does, Diagnostic appointment, you must do physical examination, so the diagnostic appointment is different from the initial consultation. So diagnostic appointment, you can now start to charge the patient. Initial consultation, don't charge the patient. Spend time with them. Show them the concise version. Show them, in fact, I let my son, my daughter, they show them the concise version, and, I'm doing something else, because the concise version is self-explanatory. Just follow everything, and then I talk to them, and we go from there. So the diagnostic appointment, very, very important. You do physical examination, and during this, you can also take certain history, all right? And then, according to the American Association of Oral and Maxillofacial Surgeons, parameter of care for planned surgery with anesthesia, a physical examination must include certain things, which include vital sign assessment, medical, and the medical consultation, if indicated. You should also take medical history during the physical assessment. Now, the patient's desire, evaluated and also documented, and the patient's desire dictates the prosthetic need, which in turn dictates the necessary bone support and abutment required. So that what the patient wants is going to determine what kind of restoration you are going to use eventually for this patient. Now, you must always document the patient's chief complaint. In other words, chief complaint, I want implant. Or chief complaint, I want new teeth. Or chief complaint, I don't want to wear denture anymore, and so on. So you must document it. All right? It's very, very important. And then, now value question asks are such as, what is the most important to you in reference to your dental health? So you can ask them, and they'll tell you. They'll probably even tell you things that you don't expect them to tell you regarding their dental health. And then during this visit, you do both extraoral examination and intraoral examination. The extraoral examination should include facial contour and skeletal profile, and then manual muscle testing and palpation of anatomical structure of the head and neck should also be done. And I suggest that you do this in the presence of an assistant, so that nobody says to you that you're fooling around with your patient, because it involves and so intraoral examination will include visual examination and palpation of intraoral soft tissues, and this should be accomplished to discover any pre-existing pathological condition, as well as to ascertain this pathological condition. Now, ask yourself, will the patient's soft tissue be able to withstand the additional stress which may be placed on it through increased function? You must ask yourself that question. And the irritation brought about through the use and maintenance of the final prosthesis. The periodontal status of the patient must be assessed, and as such, if there is any periodontal pathologic pocket in relation to the implant site, you may now do your planning to include guided tissue regeneration in your treatment. So that if I am treating the upper first premolar for implant replacement, and there is bone loss in relation to the two adjacent teeth, then I'm going to tell the patient, I need to also do this at the same time, because it's one flap and it's one surgery, so maybe what is going to cost you is a little more money and some materials, and that's it. They understand, they appreciate. The dental and skeletal occlusal classification should be done at this stage. Evaluation of occlusal contact in centric and eccentric movement should also be done. Arch form evaluation, including width, shape, and length of the arch. The arch form determines how the position of the implant relates to each other, and arch form impacts on condylar position. And this refers you to the various condylar positions which you can check. And then another thing, and sometimes I get carried away and I don't check, is the inter-arch distance. So that the inter-arch distance is going to tell you how the crowns will look, and if you are going to have any occlusal problem. Now, the distance between the opposing arches and the orientation of the occlusal plane influence the development of the restored occlusion, as well as the specific type of prosthetic component that can be used. Now, the maxillomandibular relationship must be evaluated in both sagittal and frontal plane. So this is a frontal plane, and this is a sagittal plane. Now, assess the curve of Spee and the curve of Wilson, and then the anterior aesthetics should include smile line configuration, shape and condition of existing teeth, the relationship of supporting ridge to the clinical crown length of the teeth, and the relationship of the maxillary and mandibular anterior teeth. Is it going to be the usual overjet over bite relationship? Is it going to be edge to edge, or is it going to be with a little anterior bite, and so on and so forth? And in patients that have bruxism, you may have to change the anterior relationship if it's possible, and if it's not going to create any unnecessary, undesirable change in appearance. And additionally, patients with bruxism must wear night guard mandatorily. So I'm not saying to you that you must not do implant for patients with bruxism. It can be done. It can be done. But they must wear night guard. Now, dentition evaluation should include occlusal wear of the teeth, defective restoration, dental caries, fracture and cracks in the teeth. And diagnostic cast and diagnostic wax-up will assist you and the patient to visualize the existing condition and the proposed restorative changes in the dentition. And these can be used to fabricate provisional restoration. And they can be used to fabricate radiographic stent, fabricate indices for buccolingual placement of teeth, and aid in determining the position of implant and the size and specific kind of prosthetic component to be used. So that the diagnostic wax-up is very, very important. Patient assessment for implant therapy. Basically, from my experience, this topic deals with the following broad title: assessing the patient's expectation, assessing the factors that will lead to problems for surgical placement and restorative phase of the treatment, and assessing each patient for complication. And then, assessing the patient expectation, you must consider the following: the aesthetic demand, I spoke about it a while ago, the functional demand, including bruxism, financial commitment, and this is a very important issue. You see, when I have patients that have serious problem in paying for what they want, you come, you give me chief complaint, I want implant. You understand what I'm saying to you? And then I tell you how much implant costs, and I tell you the journey from A to Z. And you know that it's a long journey. And you know that it's a very expensive procedure. Right? And you're having problem in paying, and so on and so forth. It is time to say to that patient, you are not ready for this financially, and I think you should consider other options of restoring your dentition. Don't push it. There are some that, you know, they can afford it or barely afford it. They are willing to take the risk with you. And when there is a failure, they are not going to be jumping around, writing letter to the dental council, going to Dr. A, and Dr. A will say, no, write a letter to this and that, and it leads to problem. Right? You know, you want a patient that, you know, when you do the implant, if there is a problem, they are patient and you're not God. I tell the patients, and all my implant patients, I tell them, what you are paying me to do is to replace what God gave you and you lost. You understand what I'm saying to you? What God gave you and you lost is what you are paying me to do. It's going to take time. You document how long they have lost their teeth. Some people have lost their teeth for 20 years and wearing denture. And they want you to do a quick fix for them in 6 months, in 1 year. No. We have to go stage by stage. And, you know, if it fails, I am with you. And I tell them, if it fails, don't come to me and your first approach is give me back my money. And I tell them, no dental council will tell me what to do with my own finances and with my own practice. Because when I'm doing the implant procedure, nobody knows how much I put into it. There's a lot of implants, there's a lot of bone graft, a lot of membranes, time, and so on and so forth. And basically, your patient must be willing to take the risk with you. And it's not a big risk. For them, it is financial risk and maybe time. For you, it is financial, it is time, it is moral, it is ethical, and it's also your ego. Because when your work fails, you really don't sleep unless you're abnormal. unless you're an abnormal person. You know, I mean, I have a big case in Trinidad right now that something really went wrong. And I tell you, boy, I just think about it all the time. All right? You must look at the treatment phase and time frame. You must itemize everything to them. You're going to take this, you're going to take this time, it's going to take this time. And there is no quick fix. There's no quick fix. And then the health issue. And this is how I want you to assess your patient from now on. Now, the lecture that we're going to do now is on complex immediate dental implant with bone grafting. And let me define complex immediate implant to all of you. Complex immediate implant is an implant procedure where some of the socket wall has been damaged. And once some of the socket wall has been damaged, you have to reconstruct it. No matter how small it is, you have to reconstruct it. And that is complex immediate implant. And this is a tooth that was removed for immediate implantation into the same socket. And you can see this big triangular socket wall that came out. Now, doctor, how would you...
Snip it off, put it back in, put a membrane in.
What?
Remove the excess bone, place it back in, mix it maybe with some grease right bone.
Very good. How do you remove the excess bone?
Bonjour.
You're a very bright boy. Next. And that is what I did. I went ahead, did the implant procedure, and reconstructed the socket wall. Next. And that is, actually I used 2-bone nibbler. One to hold the coronal aspect of the root, and then the other one to now nibble the bone away from the root. Now, you mustn't be too greedy, so that, because you don't want cementum in the bone. So you may have to leave a thin layer of the autogenous bone on the root. And look at the chunk of bone that I removed there. Isn't that a lot of bone? It's a lot of bone. And it is autogenous bone grafting. And that's the defect. And then after placing the implant, the autogenous bone, I now put a layer of bio-os there. And that is also guided tissue regeneration. It is guided tissue regeneration for your autogenous bone. So that it's not really a membrane that you use all the time for GTR.
So and you used no membrane there?
I didn't use any membrane here. So, then you close. Right? That's before closure, and that's closure. Right. Yep. This is a new technique for simultaneous closure of oroantral communication and maxillary sinus lift and subsequent implant placement. When you do an extraction and you end up with an oroantral communication, maybe it may be time to talk to your patient about the Ogunsalu sandwich technique and subsequent implant placement. This technique has been well documented in the literature, it has been well cited by authorities, and it has been utilized variably. Now, the advantages of this procedure is that both hard tissue and soft tissue closure is achieved in an excellent manner. It is easy, and it allows subsequent placement of dental implant, and you do not need any donor site. Disadvantages, not because it is my technique, there is none so far. Of course, there are limitations, and the limitation is that it is costly and it is technique sensitive. If you do not follow the sequence of the technique, you may have problems. Now, let us compare this to the other alternative routes for management of oroantral communication in the literature. If you do buccal sliding flap or palatal flap or soft tissue flap, soft palate slap, and often related modification, right, which have been previously done, you may have some problems. And all these techniques that I have mentioned above have a common shortfall. And I will highlight this. The buccal sliding flap reduces the depth of the vestibular sulcus. Hence, you will need to do vestibuloplasty at a later date. Only soft tissue closure is achieved, hence the need for complex bone grafting in the maxillary sinus region when endoosseous implant is considered. And severe pain and scarring will occur with palatal flap, and there is a prolonged healing period for palatal flap. And a colleague of mine, she's left Jamaica now, she's an English lady, she was practicing in Falmouth, and what she sent me a patient with oroantral communication, fresh from her office, and this was a year after I had discovered the Ogunsalu sandwich technique and used it for the reconstruction of sinus floor in a patient with aneurysmal cyst. And, I said to myself, wow, this is another opportunity for me to test the Ogunsalu sandwich technique for another purpose. And what we did was some cancellous granules of bone substitute was sandwiched between two sheets of appropriately trimmed BioGuide. Now, the BioGuide must have been appropriately sutured on 3 sides with resorbable suture so as to look like a pillowcase. And after the bone substitute has been placed inside, then you now stuff the the bone graft material inside it, and you suture the fourth side. Now, the sandwich is prepared in such a manner that the smooth side marked up and the smooth side and the rough side is present. But with other membranes, this is not so. Other membrane, you can use any side. But the way BioGuide did their thing, you have to do it that way. And this is the pillowcase. And when you finish your sandwich, you tuck the sandwich into the oroantral communication in such a way that the convexity is facing into the sinus and the concavity towards the alveolar bone. Now, fill additional bio-oils into the concavity. Remember, you're going to have a concavity facing, so pack some alveolar bone, some bio-oils or bone substitute there, and then you close. And your closure should be watertight. You may have to do some marginal alveolectomy. And look at this. This is the oroantral communication there. And this is lovely. This is day 1. Look at the sandwich in there. Now, because you pack it like this, so what you're seeing on Panorex like so is this mountain, like so. Right? And then bone graft inside the concavity. And check this out, 8 months later, thick floor of the maxilla and regenerated alveolar ridge. And of course, at 12 months, I placed implants in there. And just last year, I was very excited. I got the Implant Dentistry Journal issue, I think it was for June last year. And as I opened it, in the content, I saw management of oroantral communication with implants. And I smiled, and I said to myself, I bet they must have quoted me. And when I opened it, and I looked at the article, the discussion part of the article started with my name. Discussion part, Ogunsalu in so and so. And I said, wow, this is nice. And really, this technique is such that, people write me day by day. Especially a lot of communication from India, to the point that people want to do MPhil in India in oral communication on my technique, and they want me to supervise them and this and that. I just say to them, I don't have to supervise you. Any PhD there can supervise you. Just go ahead with what my work is in the literature. You can use my work. It's not a big deal. So the role of quantitative single photon emission computerized tomography in the assessment of osseous integration of Ogunsalu sandwich technique was a problem that I tackled during my PhD work, and it was something that I was thinking about after I did this technique. This next lecture is on dental implant and odontogenic tumor, and I'm not going to waste so much of your time going through the slide one by one. I'm going to just let you appreciate that odontogenic tumor is a very highly recurrent odontogenic keratosis is a highly recurrent odontogenic tumor. And when you remove it or enucleate it, you stand a chance of it recurring. And with regards to the enucleation of tumor which are recurrent, patients still want rehabilitation. They don't want to be going around with a defective jaw. So that implant treatment has a role in this management. Now, despite the possibility of recurrence for amyloblastoma and odontogenic keratocyst, it is becoming a mandatory practice to rehabilitate the edentulous mandible with implant retained prosthesis and provision of removable or fixed, temporary or permanent restoration. This lecture presents a case of odontogenic keratocyst with amyloblastomatous transformation in a 21-year-old Jamaican female who had cryosurgery as definitive treatment. Let me tell you the sentiments attached to this patient. The patient has odontogenic keratosis, a tumor which on its own recurs very often. And it is not a straightforward odontogenic keratosis. The lining has transformed in some area to amyloblastoma. And when you look in the literature for amyloblastic transformation of odontogenic keratosis, it is extremely rare. In fact, the paper was accepted by the Journal of Oral and Maxillofacial Surgery in America, and then one of the reviewers said to me, I don't believe that it has amyloblastic transformation. And I want you, we're going to accept your paper, but we want you to change the title that it is not amyloblastic transformation. Of course, that is a lie. Because Professor Anchard, an authority, did this histology. And I will show you the amyloblastic transformation here. So that basically, yes, I changed the title, but I still reflected into this stylishly. In that I call this odontogenic cyst with transformation. I've forgotten how I phrased it. I've forgotten. But at the same time, I published a series of odontogenic keratosis with this inside, so which I referred to in this paper. And the other sentiment is that for the first time in the world, keratosis was treated with cryosurgery. In other words, the use of liquid nitrogen. All right? And I also found out that using liquid nitrogen leads to excessive osteoblastic activity. You form a lot of bone, and you will see shortly. Next. Next. Now this is poor radiograph, extensive radiolucent lesion, and you can see in some area the beginning of auto-amputation of the roots. Next. 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 Now, this is what I want to show you. You see that? This is amyloblastic transformation. Next. And these are islands of amyloblastoma. Next. And then 5 years after, next. Next. After enucleation and just leaving a thin lower border, look at the amount of bone that formed. So what I did was I placed 3 implants. Next. Next. And 1, 2, 3. So no, go back. O-ring, O-ring, and of course just to show you the external hex of the 3rd implant. And this is clicking on to the undersurface of a lower full denture. So that the use of implant is not just limited to replacing single teeth or multiple teeth. Next lecture. Now, I want you to listen to this lecture very well. It is a lecture on the oral surgery complication of dental implant. I will not pretend as if I'm a restorative specialist. I am not. And maybe Dr. Emerson in a few years' time will come and stand in front of us and lecture to us on the restorative complications of dental implants. Of course, there must be quite a few, or a lot. But what I did was I sat down and I divided the complications of implant surgery into reversible or irreversible, immediate or delayed, and site-specific complication. And then I also divided the complication according to whether it affected soft tissue or whether it affected hard tissue. That's the only tissues it could affect, soft tissue or hard tissue. And when it occurs, it may be site-specific, it may be immediate or delayed, it may be reversible or non-reversible. And then I categorize complication related to instrumentation. And, you know, these are some moods that I get into, and I do very nice things. I just sat down and I was thinking, and I said, you know, this is how we can classify. And there is nowhere in the literature that you will see this classification. All right? Like this. So let us look at site-specific complication. And this takes us to postgraduate training. You know, if I want to fail a whole set of postgraduates who have not attended my lecture, I can do it. It's just a matter of saying to them, A 45-year-old had maxillary sinus lift procedure in relation to the upper first molar. Discuss the various complications of the surgical phase of implant treatment in this patient. So, most times you see people writing, damage to the inferior dental nerve, perforation of it. I'm telling you, postgraduate, right? So site-specific, you must focus on the question. He's talking about maxilla, and he's also talking about first molar region. And once I see those garbage there, I don't read it anymore. I just give the person 3/10, and I go and do something else. Let's give 3/10 for writing something. I don't give anybody 0. Once you write an essay and you put 2 lines there, you deserve 2 marks, or maybe 3. And then when you write garbage, some completely garbage, from I see inferior dental alveolar nerve damage and so on and so here, right? There is no way you can score 3. You can score more than 3. And if you write a comprehensive essay on the other aspect, I will still say no. Let somebody else mark it and give you whatever they want to give you. So, in the maxilla, you can have perforation of the maxillary sinus. And this is a reversible complication. You can have dislodgement of implant into the maxillary sinus. So that patient yesterday, after the extraction, and we are putting in you saw how I was behaving very gentle and so on and so forth, and treating the area with care. If I was aggressive, it could have gone into the maxillary sinus. And if it went into the maxillary sinus, it's a very easy treatment. It is reversible. Just put a small suction in there, right? Maybe enlarge the opening, and you suction out the implant. And then you could have perforation of the nasal cavity, and this is why people are now doing subnasal augmentation. However, some years ago, experiments were done in dogs which allowed deliberate perforation of the nasal cavity, and all the implants also integrated. So that the issue of nasal cavity perforation is neither here nor there with regards to the eventual osseointegration of your implant. And then, damage to the root of adjacent teeth is reversible and it is irreversible. You see, huh? And surgical emphysema is reversible. Infection is reversible. Next. And then in the mandible, these are the things that can happen. Damage to ID nerve, mental nerve, surgical emphysema, or damage to adjacent teeth, or damage to soft tissue. And then with regards to complication relating to instrumentation, surgical emphysema, which I have had, and then fracture of the jaw and infection. And in fact, in the mandible, what surgical emphysema is going to do to your patient is that swelling is going to press hard on the inferior alveolar nerve. And despite the fact that your implant is far away from the inferior alveolar nerve, the patient will have abnormal sensations such as numbness or paresthesia in that region. And you will be wondering, but I did my measurement right, it's far. And you will realize that when you order implants the way I order, Emerson was very surprised yesterday that I said I order 4.1 and 9s, mostly 4.1 and 9s. And, they fit into any situation. You're happy. Yeah, I just make life easy. Right? And then when you have complication, and this is the meat of the matter, Max, Gabriel, and Judith. This is the meat of the matter. Your complication may cause discomfort to your patient. So you'll have to be able to communicate with your patient and let them know that you are with them. You understand the problem they have, and you are doing everything to solve the problem. That is going to lead to peace of mind for both of you. Infection can occur from complication. Pain can occur. Numbness can occur. Lack of osseointegration or even delayed osseointegration can occur. And if you hide things from your patient, medical legal will occur. When things happen, let it be that you are the first to tell the patient and say, hey, you know, this has happened and I know what to do. I'm going to correct it. Right. Lecture before, but I'm just going to review it with you again. Grafting of the maxillary sinus in the region of oroantral communication. And this is with subsequent implant placement. And I've talked to you about all the advantages, and this includes both hard tissue and soft tissue closure. It is easy. It has no donor site requirement, and you can place implants in it. And there's no disadvantage, and the limitation is that it is costly, and it is technique sensitive. I've described the comparison with alternative methods to you and the problems that the alternative methods have. The technique is simple, and the construction of the Ogunsalu sandwich bone regeneration unit. And the reason why I'm reviewing this with you is that I do not want you to miss an MCQ question. The sandwich itself is a bone regeneration unit. It is not a technique. The sandwich in your hand is a unit. It's called a bone regeneration unit. Right? It is when you use it for bone regeneration that it transforms into a technique. So don't miss that MCQ question. All right? Next. And, let's review the X-ray again with regards to, you see the oroantral communication, Dr. Chukwu, see that? And then look at the amount, look at the sandwich in, and subsequently, bone formation. Okay? So, that's that. It's a very short presentation. Dental implant therapy in the management of juvenile periodontitis. And the reason why I'm presenting this to you is for you to appreciate the fact that juvenile periodontitis is treatable, it is controllable, you can limit it, and you can even use implant treatment for juvenile periodontitis. And one of the things that we're going to do today is review some of the restorative work that I've taken impression for over the last 1 week that I should have sent from last week to the United States. But because I wanted to use it to teach you, I decided to keep them here. And one of them is a patient with juvenile periodontitis that we have actually used implants in her management. Not this one. Right? We use implant also in this. Right? But we have not finally restored her implants. But the other one, we're going to finally restore her implants. Okay? Now, this is a pre-operative clinical picture of this patient showing pathological migration of the upper central. And all of you can appreciate what is happening here. The upper central has migrated apically, in the occlusal direction. And this is her radiograph. Sorry about the scratch there. And of course, when I raise the flap, this is how it looks. And what I did here was I placed 2 implants. But basically, my photography is bad. Now, it is my photography that makes these 2 implants look close to each other. But the X-ray is going to show you that I am okay. But what you see is that there is dehiscence. Okay? Can you see the dehiscence there? All right? And what I did for this patient was I took autogenous bone graft from the nasal septum. Remember, in the same area, you just extend the flap and you just nibble. Next. And then closure of the operative site and with the caps in place. And look at that, neat closure. And then we look at my implant. All right, next. And that was her temporary restoration. She was very happy. And the most important thing in this patient is that you must do microbiology. You must use a swab to take specimen for culture and sensitivity. So that in this patient, we found that there was Klebsiella species growing. And these are all the antibiotics that we can use to kill this Klebsiella species. And I can remember I chose oxytetracycline. And we achieved what we wanted to achieve. And the lesson to learn from this is that juvenile periodontitis is not hopeless, and the use of implants in this patient is permissible. And we have this case that I will discuss with you. Of all the implants that I placed, I think I placed 5 implants for her. She lost only 1. Only 1 was lost. And I don't think it was lost because of juvenile periodontitis. Next. Next lecture. I love giving this lecture. Impression taking for dental implants and communication with the laboratory. You must be able to communicate well with your laboratory. Otherwise, you will suffer and your patient will suffer. Impression taking of dental implants is one of the most important aspects of dental implant therapy. The impressions are obviously used to produce cast, which will subsequently be utilized for the fabrication of implant retained prosthesis. Since patients are mainly interested in the appearance of the finished work, it will be reasonable to accept that any shortfall in the impression taking may lead to unnecessary requests by the laboratory for a repeat impression. So just imagine me sending impression to California, and then they say, Dr. Gonzalo, the impression is not good, you have to take it over again. That means, and then sometimes my patient may be from Grenada or from Bahamas or Barbados or even New York. So who pays the patient's flight to come back? And then you will now spend time to take the impression and then send it back. So the best thing is to do it right the first time, right? So repeat impression is unfortunately a very expensive procedure, as you will soon find out in your practice of implantology. And I will explain to you why it could be an expensive venture. And I will attempt to describe impression taking by using a single tooth replacement case for you. Now, believe it or not, this is an implant site the patient has an implant there, and this is a bonded composite restoration as my temporary restoration. And one of the problems of this kind of restoration for implant patients is that when they come back for the impression taking, you will have to drill this out, take the impression, and then now give them back another one. You know, it takes time, and once you give them this, they want it all the time. And I do it for them, huh? And I prefer it to denture, because denture may, especially if you do bone grafting, denture may disturb your integration. So, this is a clinical picture of a patient with temporary restoration in place in position number 21, which had a 9 by 4.1 endopore implant. And this was 8 years ago. So you see, I've been using my 9 by 4.1 8 years ago. Right? Next. The trays are the same. There's a restorative kit which has a lot of things in there, impression copings, analog, and what you do is you remove the temporary restoration and check the stability of your implant. Always check the stability of your implant, and then remove the healing abutment or the cover screw. And that's the healing abutment removed. And look at that nicely sunk implant. It's lovely. The only way you can remove that implant is to drill it out like you drill a wisdom tooth out. Okay? This is the impression coping. Select the impression coping you're going to use. And if what you do is you do 4.1 millimeter all the time, then you have them abundant in your office, impression copings, abundant in your office. And this is a hex driver. So this hex driver is going to be engaged into this aspect of the impression coping. And then you now connect the impression coping by screwing it into the implant. All right? And that is what I'm talking about. So this end is screwed into the implant. And I've always used Impregum. I just love to do it. I have the gun, but I enjoy mixing. So you can use any impression material you want to use. You can use the gun. You may decide not to use the spatula. I mean, it's up to you, right? And once the impression coping is in, you take your impression, and it's just the same way as you do impression for crown and bridge. I see so many kind of impression technique described in the literature. This open tray, this, that, and that. I just do simple things that make me and my patient happy. Next. So you remove the impression after setting, and then you unscrew the coping from the implant, which you can now transfer into the impression. Now, the endopore implant system, the impression coping, has a flat side, one flat side. They designed that flat side so that you may want to put that flat side to face labial all the time. And I have a colleague, Professor Tim Hotto, which Dr. Zor and Emerson know very well. He lectures on my course, and he's now the dean at the University of Tennessee, of the Dental School, University of Tennessee. He always makes sure it is labial. But I'm telling you, I don't, huh? I just screw it in. Wherever I stop, stop. And again, my technician knows me. My technician knows that I don't make it stay labial or distal or... So, you know, I will teach you tomorrow to always keep it labial. You understand me? It's a practice. I can do it, eh? I can always keep it labial, but I just don't care. Because keeping it labial or not keeping it labial, it doesn't disturb anything. All right? So teaching you to keep it labial is a discipline. All right? So you now orient your impression coping back into the impression. Next. That's it. Now, so that is a impression coping back into the impression. Now, I deliberately use this impression for teaching purpose. Because I want to let you understand that for this single tooth restoration, all this defect here does not matter. This is what matters. You understand me? So don't discard this and say, oh, it's not a good impression. Right here is so lovely. And that is what matters. Next. And then you now don't forget to put back your healing abutment. And all the time, especially when you are doing multiple cases or you have other patients waiting, you end up not putting back your healing abutment or cover screw. And that creates a problem for you and your patient at the next visit. As such, these are the training that you have to give your assistant. In fact, I train my assistant that when I am doing impression taking for multiple implants, you listening to this? That my assistant is responsible for me putting the impression coping into the correct hole. So you must watch me because it's multiple, huh? So I may take this one out from this place and go and put it in the wrong. You are responsible. You must tell me when I make it. That is your responsibility. All right? Next. And this is previously I'll take the lower opposing impression with with rubber base and just send it to them. But now I take it with alginate, cast it, and send it to them. Because impregum has become very expensive in this environment. Take a bite, which you can do in rubber base or with wax. I do wax all the time. And then, the age of the patient is important to my technician. The name of the patient is important. The sex of the patient is very important. And when I don't put the sex there, he calls me, what's the sex of the patient? Very important to him. Right? The name of the dentist, because in my office in Trinidad, I'm not the only person working. Very important. And then the type of the implant and the location. But the type of the implant, you see, if it's endopore, he wants to know, so that if he's going to buy the analog, he knows which company to call, right? And the diameter is very important. And the type of restoration you want and the shade is very important. And I will introduce all of you to Vincent and probably let you speak to Vincent today so that I'm telling you the truth. He is very good. And what I want you to do is when you get into oral surgery residency, you'll be collecting the chicken change that they give you in residency because you are training. It's little money they're going to give you. And then you fly down to, if you're doing it in Boston or wherever, the same practice, you'll be doing implant there. On a Saturday or Sunday, they book about 10 patients there for you. Just do it. And you go back to school You sit down like an innocent boy. Okay? That's what you want to do. And by the time you finish oral surgery residency, and you are medically qualified, dentally qualified, and you are a specialist, you have an implant practice. You know, so that is how you want to do it. You don't want to abandon everything because you're going to school. People don't do that anymore. Okay? Now, let us look at another impression. This is a full mouth, and this case is a very interesting case in that I did 3 implants for him in the maxilla, 3 implants in the mandible, and a dentist said to me, oh, I can restore it. Chris, I do a lot. And he's a big shot dentist in Trinidad. I do a lot. You know. So I said, he couldn't even hold a hex. He didn't know how to hold a hex. And he damaged all these implants. He damaged all the 3 in the mandible. So I had to redo the case. And I could only end up putting 2 implants in the maxilla. And this is what we ended up with. And then we ended up putting mini implants here and there for this patient. And I tell you, and this is where things are not done evenly. The patient paid him a lot of money for restoration, which is what he should charge, really. It's a lot of money. He should charge it. He sits on the Dental Council in Trinidad and still sits on the Dental Council today. Patient wants refund, he never gave the patient refund. And every time you sit down in the council and they put complaint under the table. The Dental Council members never get complaints, you know. They never get complaints. And that is why they scramble to be on the Dental Council. I'm telling you the truth. And that patient wanted me to help him to get back his money. I said, I don't do that. What I have done for you is I've put back all the implants without charging you, huh? And I've restored it for you by you paying just the lab fee. And every year from 2004, 2005, he takes me, my wife, and my children for dinner. Mandatory. He sends me Christmas card and he sends me 2 wines. Every year, because he appreciates me. And I think I was a gentleman. I never created any mischief with anybody. You know, I could have gone to the press with this and said, patient, go do this, go do this. No, it's not necessary. It's not necessary. Because, I mean, in fairness to him, he did the restoration. The restoration came. But he just couldn't, he didn't know how to fit in the restoration. And he avulsed implants with the torque wrench. And he was avulsing them serially. And not changing his technique, you know, of the use of torque. So that it is important for you to go for hands-on training. Don't think because you have a practice with 10 chairs and some guy from the US flew into your office some years ago and did some implant and you look what he was doing. You can now do implant. No, you have to go for hands-on training. Next. And again, this is a multiple implant case, 1, 2, 3, 4, 5, you know, and I do them. I mean, I remember this procedure. This particular patient took me just about 30 minutes to sink in all the 5 implants. And then this is a case which I did implants in the anterior, and I will show you the surgical procedure that I did with him. It was the first patient that I used Interseed, resorbable membrane for. Next. That's it. So Interseed is a new clinical material for GTR, and this brings us to the question, how much space do your membrane have? And sometimes you want to put the conventional membrane there, and you realize that your tissue can't cover it. So maybe it is an opportunity to put a thin layer of Interseed there, which you can fold and is very compressible. All right? So, what is Interseed? Interseed is a resorbable barrier membrane used normally in gynecological and other abdominal surgical procedures. In oral surgery, it is a resorbable material for GTR, and it was first used by me in a palatal post-surgical site and alveolus after cyst enucleation. And we did immediate implantation for this patient. Now, what is significant about this presentation? Its first use by me was of great success, and there was no report in the literature that Interseed had been used for the purpose of GTR. And of course, before I sent my paper out for consideration for publication, I discussed it with a friend in Trinidad, and he said, "Oh, Chris, I used it in so year, but I didn't take him on, I mean, if he uses it, he can publish it. I have no problem. Because of the ease of use and the low cost, it is no more cost. It is no more low cost. It's very expensive now. And more importantly, the high success rate obtained in terms of guided tissue regeneration, the stabilization of the bone graft, and hemostasis with additionally no exposure of the membrane, we suggest its continued use as an alternative membrane for GTR. In fact, my paper on GTR has been accepted for publication in the Implant Dentistry Journal, and I'm going to get it published very soon, and also I'm going to get another series of paper on Interseed validation, histological and SPECT, published also. And it's an ideal material. An ideal material for GTR must exhibit all these qualities, including biocompatibility, tissue integration, separation of cell, space maintenance, and clinical manageability. It must conform to all that. Now, this is the case. Upper Central, I think 21-year-old final year student in the university, discolored, fractured from he was 9 years old, and you can see the apex is still wide open. All right? And there was a big cyst there. And Emerson, what we did was we raised the flap, and you can see that big palatal bag there. You can see it's a cyst. Next. Next. And then we remove the two teeth. Look at my socket. There's no damage to the socket wall. Next. Placing the implant. Next. And you see the space there, huh? The peri-implant space, huh? You must tuck in bone graft around it. If you don't tuck in bone graft around it, soft tissue is going to grow in there faster than. Soft tissue is going to go in there faster. And at the least, you can put just a membrane there, so that soft tissue is not going to grow, and the socket is going to heal like extraction socket. All right? Next. I'll take questions very soon. So this is BIOS bone graft placed there. And then next. And then I used the interseed resorbable membrane to cover the bone graft, and that was the first case I did. And you'll see that I used a whole sheet of interseed because I didn't know how to use it. So I put a whole sheet there, and then I also put interseed in the palatal defect. Next. And this is a picture post-op. You can see that. And you see this cyst, You see that's a palatal cyst that you're seeing here. And if I have time, I will show you his picture, his panorex 3 years after. All this is bone. Okay? Next. And that is a case that I used interseed for. It was very successful. Introduction to practice management. So practice management essentially deals with meeting up to the patient's expectation. And when I'm talking to you about practice management in this regard, I'm talking of dental implant practice management. Of course, a lot of the things I'll be telling you can be utilized for other aspects of dentistry. And a practice manager must be able to reduce the stress on the practitioner. You don't need a practice manager that is coming to tell you this all the time, this. Somebody that will do things for you. You know? So I tell Mrs. Thomas that, you know, my job in this place is to talk to the patient, tell them what needs to be done, diagnose them properly, treat them, and it is your job to do all the other things. You have to do all the other things, and you can't bug me with all the other things. And you can't come and be telling me this and telling me that because you don't know what is in my head at the time you come and tell me this or that, you know. So, I mean, you have to manage the practice. And that is the role of, if you have a good practice manager, then 70% of your problem is solved, Not 50, 70. And I'm sure Emerson has very good practice managers. I know 2 of them very well, and they've been there for years, And I congratulate you. And then the organization of other staff. The practice manager must be able to organize the other staff and organize me. So once a practice manager cannot organize me, there is a problem. I need somebody who is going to tell me that this is what you have to do at this time. And probably not say to me verbally, but maybe put it somewhere there or make a sequence to let me know that this is what we have to do at this time, this is what we have to do at this time, and so on and so forth. Yeah. And of course, ensuring profitability. And, you know, many a times I want to be very nice and I want to give discount and this and that for my implant case. And I tell you, my wife doesn't like it, because she says it doesn't worth it to give these discounts. Let them pay for what they want, and if they can't pay for it, it's not a, you know, maybe at another time they'll be able to pay for it. But I don't really believe that. I think in a way you have to help them, and you have to give discount, but you have to draw a line. Now, and of course she tells me that the patients that we give discount to are the patients that end up trying to pay in a very haphazard way. You know? And an example is a patient that for years, you know, he's been saying, yeah, he's going to do crown and bridge. He never did it. And then his teeth are moving very badly. Every time I give him a discount and say, hey, you have to do this thing, you know. And then he came just last week, and he's a patient that canceled for the mini implant. I was going to do 2 Atlas implants for you guys and load it today. But he canceled. To ensure that he's able to do it, he's a banker. To ensure that he's able to do it, what I did was I just calculated the cost of the implant and the components for the restoration. And I think it came to like about 50,000 Jamaican dollars. And I said to him, Mr. So-and-so, just pay the cost of the this and that, and I'll do it for you. He was happy. He said, yes, he's going to do this. And then I told him, I said, I can't do it for you on the course without you paying and signing X, Y, Z. And for 1 week, he said he's going to bring the money. He never. And then last week, he had a problem. And he had some concern about the implant, whether he'll be able to go to work and this and that and that. I solved his complaints, his concerns. And then he said, yes, you can send somebody to pick up the check. And then he called me, and then he said, boy, the check is, he looked into his account and he can date it only for August, right? And just hold on. So I said, you know, what you have over me is that I want to use your case to teach people. So I said, okay, I'm going to send the person to pick up the check from you. And yesterday he told my bearer, he said, yes, send your bearer, send your bearer. So they went to him in the bank, and he said, oh, you know, his checkbook is in the car, and he actually had an accident over the weekend, and the car is by the repair place. I mean, most likely it's a good story, it's correct, you know. But then I just canceled him. I just told my office, just tell him, no problem. And this same patient, when they now see a gross discrepancy in appearance, their eyes will now open, and they now come. And that is your own chance now. No discount. That is your own time now. No discount. So, ensuring profitability. Next. So I will attempt only to talk on practice management as it relates to implantology. Implant patients are different and difficult at times because they have very big and sometimes unrealistic expectations, which I have mentioned to you earlier on. They usually spend a lot of money on this treatment, according to them, and they want to have the best. They tell you all kinds of things. They will even tell you that, you know, I don't want you to join the teeth together. I want them single, because I want to be flossing. They tell you all kinds of things. And it is for you to tell them that, hey, if you don't join it together, There's going to be this problem, there's going to be that problem, you are not seeing what I am seeing. So the following area assists in an effective dental implant practice management. Communication skill. You must be able to talk to your patient about the advantages of tooth replacement with implant versus traditional restoration. You must have a customer service skill, and you must listen to your patient. And simple discussion on implant-related topic is also very important. And sometimes I just sit down and I am listening. You'll see a nurse came in here earlier on, you know. Apparently she came to make some payment and so on and so forth. And, you know, she has TMJ, myofascial pain dysfunction syndrome. And after we examined her and so on and so forth, before she was referred, and we knew she was coming for TMJ. So right here in the waiting room, I must have talked to her. She really wanted to talk, huh? So we talked. We must have talked for about 45 minutes before we went in. And that talk actually gave me an insight to the etiology of her problems. And then we talked more inside. We came back, we talked more. And I tell you, you know, her management is straightforward and easy. I'm going to show you a patient of yours with TMJ problem that I did orthodontic surgery for some time ago. And I think Beck did the orthodontic treatment after. Very interesting case. I kept the model for you just to have a look. So patients will ask you a lot of questions, and the ability to be able to answer these questions precisely is very important. They will ask you if it hurts. They will ask you what the procedure entails. And, you know, a lot of times they ask you, okay, how much does it cost? And then you are fooling around and you are peeling your fingernails and saying, well, you know, it costs so amount. You know, no. You know what it costs. Those things irritate patients, huh? You know what it costs. Look at them in the face and say, this is what it costs. And if looking at them and telling them what it costs is going to make them walk out away from you, no problem. And the way I look at it is that, you see, my sleep, huh? And my relaxation is very important to me. So that when I don't have patients, or when my patients cancel, even when I travel all the way to Trinidad to treat patients, half of the patient cancel, I'm not worried, huh? I sleep, I relax, I do other things, huh? And spend time with my family. And then when they ask you, will my insurance cover it, or can I use the insurance to cover this part and this, just tell them it is fraudulent. No insurance pay for implant in Jamaica. No insurance pay for it. And they'll tell you, okay, is it possible that because I have 50,000 there, you know, so maybe you can, just tell them you don't do it. Tell them you don't do it. And you don't have time to do it. And then, how do I pay? Pay credit card. I accept any form of payment from my patients. And in 20 odd years of accepting checks, huh? Maybe I've only accepted 3 or 4 that bounced and I never got my money back. Huh? Big box, but no problem. But I still accept checks. It's a form of payment. It's a form of payment, and I accept it. Management of fractured final abutment post-restoration of dental implant. And this was a patient from a colleague of mine from Kingston, and apparently that patient had implant treatment done some years ago from this colleague of mine. Next. And something happened. So you'll see now. Occasionally, one may encounter a fracture of the healing abutment screw post-restoration. As such, the various available options for management must be known to the clinician. All right? And again, only cheap implants will have those kind of problems. And that is why you have to have a track record for the implant system that you are using. I've had so many implant companies that have offered me so many things for them to just infiltrate the Caribbean market. And I just say to them, your implant is saying nothing. Your implant is saying nothing. And the fact that you are selling it for $100 or $120 does not mean that that is what we're going to be using here. No. So, the option is to unscrew and redo the restoration using the previous record. But to unscrew, because it has fractured, you can't unscrew it. There's nothing to hold on to. Another option is to drill into, or you're going to destroy the thread if you drill into the fractured screw. And then another option is to remove the implant. All right? And the other option is to abandon the implant site and choose another site. Of course, communication with the patient as regards to what you are going to do is very important. And if you are not the one that did the implant, it is very important for you to communicate with the person who did the implant. And when patients come to me from other people, I communicate with them, even if they are not my friends. I say to them, your patient is with me, and so on and so forth. This is, how we're going to do it. And sometimes, what has happened is something that can happen to you also, or something that has happened to you before. So help your colleague. It's not an opportunity to make money or to show that you are superior. Next. It is also very wise to communicate with the person that placed the implant, like I've told you, right? Now, let us look at the case of Mr. R.S., a Pakistani patient with oral submucous fibrosis. If you know what submucous fibrosis is, it is a condition where the patient has lost the elasticity of the mouth. And the patient I did the flap surgery for in Kenya, that last patient I treated, he's developing submucous fibrosis. There was no elasticity. And by the time I finished, my whole hand was paining me. Because you have to be retracting with force. The patient presented to me in the year 2000 with a fracture of abutment of implant in position number 36 post-restoration. And that is it. So the abutment screw was still there. So what I did was I tried to drill this out, but so that I can put a wider diameter implant there. But you see, he couldn't open his mouth more than... And really, when he opens it for about 3-4 minutes, he just push you away. Very rude man. Just push you away. But because his mouth is tired, no elasticity. And I almost said to him, there is nothing I can do for you. There's nothing I can do for you. But his history was that he went back to the dentist who did it. And the dentist said to him, I'm sorry, I cannot help you. My hands are too big for your mouth. So which means he realized that something has happened. That the patient has, but he doesn't know the diagnosis. So took history from him, and he used betel nut and all these things that were predisposed to submucous fibrosis. I made my diagnosis, and then, I looked at the x-ray again, and I said, wait, this is a piece of cake. I said to myself, this is a piece of cake. I said, this tooth is actually clinically mobile. It has lost a lot of bone here. So maybe I can talk to the patient and tell the patient that I will remove this tooth, put an immediate implant there, remove this crown, and bridge. Of course, this tooth is moving apically, and there is pathologic pocket there. Next. So that is exactly what I did. So I removed that tooth, placed an implant there, and the fact that you super sync an implant does not mean that it's going to be way down. You see, it's at the same level there, right? And Dr. Gabriel, Dr. Chooks, yes, look at that. Immediate implant. Next. And we bridged. And this patient has been very happy since then. He doesn't come for review. I see him everywhere. I mean, even see him in Kingston. The last time I see him in Kingston was just about 2-3 months ago. I said, Mr. RS, you need to come for review. And he said, yes. I said, okay, they'll call you. And then they call him, and they tell him I'm okay, I don't need to come for review, So that's the way I like my implant patients to behave. But then they need the review. And then I myself, I need to see my work. I need to see what my work looks like 10 years down the line, Now, we're going to talk about peri-implantitis. Now, according to the first European workshop on periodontology, that is Albert Kelston Isidore in 1994, peri-implantitis was defined as the inflammatory reaction with loss of supporting bony tissues around the implant which is in function. And remember their definition, which is in function. However, peri-implantitis can refer to peri-implant bone loss of implant which is not in function. All right? So that when you're writing your essay for us, and you know that your essay is due midnight on Sunday, right? Your essays are due midnight on Sunday. If you have any issues, talk to me, huh? Next. Now, the editor of the American Academy of Implant Dentistry Journal stated it will be wrong to use the pseudonym peri-implantitis to denote inflammation or infection around an implant, as implants are metal, which is neither an organ or tissue. And that is right. Okay? As such, the American Association of Implant Dentists decided that the appropriate term to utilize is implant histoclasia or peri-implantoclasia. So that is a new word for peri-implantitis. Peri-implantoclasia or implant histoclasia. You understand me? And you know, this has medical legal implication, huh? Next. With due regards, the definition of peri-implantitis has changed considerably, having incorporated into it the progression of the disease as well as the progression of osseointegration. Now, it is now appropriately defined as chronic inflammatory process with bone loss and pocket formation around an implant. Clinical studies have documented that implantitis will result in a rapid osseous destruction due to the connective tissue capsule not enclosing the entire implant. Inflammatory cells heavily infiltrate this capsule, which was composed of loose granulation tissue. And basically, this is one of the reasons why you want to ensure that from the start your implant is well seated in the socket and there is no issue of space between the socket and the implant surface. Implants failing due to peri-implantitis are generally characterized by suppuration, presence of bleeding on probing, pain, increased probing depth, and mobility. They may also have halitosis and presence of radiographic evidence of bone loss. All the above clinical symptomatology, except 4 and 7, are clinical signs elicited by the clinician. In other words, the presence of radiographic evidence can be elicited by you. That's a sign. So when you're writing your essay on peri-implantitis, you must separate sign from symptom. Whilst peri-implant disease is a collective term which is used to describe an inflammatory process affecting all the tissues surrounding an implant, peri-implant disease may be divided further into 1, peri-implant mucositis, which is a reversible inflammatory process affecting the soft tissue surrounding the functional implant. Peri-implantitis is a controversial term, which in essence is an inflammatory process affecting the tissue around an osseointegrated implant in function, resulting in loss of supporting tissues. A mean loss of crestal bone height of 0.9 millimeter to 1.6 millimeter during the first year of post-implant placement is normal. And I tell you, hence a good reason for supersinking implants. Because you don't know what is going to happen. And also, bone loss of 0.02 millimeter to 0.15 millimeter annually in the following year is considered an acceptable condition for health for most implant systems, though authors differ on this. There is a lack of universal parameter to denote health and disease around an implant, and you need to appreciate this. Also, one must begin to wonder the lifespan of an implant if it continues to lose bone annually by 0.15 millimeters. As such, The dearth of literature for now reveals an incidence of 0% to 14% or 5 to 10% for peri-implantitis. Let us look at the etiology. Now, subgingival anaerobic bacterial plaque resembling those of chronic periodontitis are involved. Stimulation of the body defense mechanism through inflammatory infiltrate or allows inflammatory infiltrate to accumulate, and then they release toxin, and this results in the destruction and resorption of peri-implant bone. As the plaque migrates apically, the clinical and radiographic evidence of the disease becomes more and more apparent. Presence of excessive biomechanical force, which leads to microfracture, and that is what happens. A microfracture between the implant and bone interface, and this leads to deosseointegration. There's a deosseointegration, and this is how you write your essay. And with regards to radiographic feature, varying degree of vertical bone loss is evident adjacent to the implant. This bone loss may be saucerized or wedge-shaped defect. Nevertheless, the apical portion of the implant appears perfectly osseointegrated, and that's what happens. With this vertical bone loss, you have formation of peri-implant pocket, which is called pathologic pocket. Now, when you are writing an essay on peri-implantitis and its management, you have to divide the management into two. One is investigation, and one is treatment. You cannot treat something that you have not investigated, right? So that the investigation will include history, clinical examination to confirm all the above mentioned signs and symptoms. And then I always like to do microbiological investigation for culture and sensitivity. And then you can do further radiographic assessment to appreciate the advancing nature of this disease. Now, immunological investigation may be indicated. Now, I will show you the form I have in my office that I fill for my implant patients. And I ask direct questions like, do you have HIV? And for all other patients, I will ask it and I will just document it, yes or no. For implant patients, I say to them, do you have HIV? If they say no, and when there is a portion there that they sign that they've given me the correct history. So when they sign, I say to them that at any point in time of my management, I may want to cross-check any of these by laboratory investigation. In other words, you say to me, you are not diabetic, and I feel that you're getting recurrent infection and so on and so forth. I want to find out. So I have my glucometer and so on and so forth. I don't need your permission. I'm going to just prick you to find out what the situation is. Similarly, I can do that for you and test you for HIV. And I had done multiple implants for a patient. I told somebody recently in one of the small islands, and I noticed that the implants were failing was failing like crazy. And I was like, this is implant I sink in solid bone. And of course, I become very friendly with the patient. And then the doctor for the patient, his physician, was also somebody I was close with. And, you know, it was the physician who stylishly told me that, say, Chris, you think HIV can cause all this? He was telling me something, huh? And, you know, instead of commencing any investigation or redoing treatment or what have you, I just gave the patient back the money. I've done a lot of work for him. I just gave him back. I said to him, you know, I mean, it's not fair on you that I'm not willing to take a second chance, and, you know, most likely you're going to be using dentures. You know, because I wasn't bothered. I didn't want to bother to continue. And again, you have to investigate into the market for the available GTR materials that you can use. And your investigation must also include what your patient will accept from you. You cannot give a 7-day Adventist BioGuide. You cannot give a Hindu who does not do cow BIOS. You must find out the patient's habits, such as bruxism, which is a psychobiological behavior. The consumption of alcohol and tobacco must also be investigated into. Before the treatment, one should identify the etiology and eliminate this etiology if possible. I love for you to do this. You can start your patient with empirical antimicrobial treatment to find out the result of your culture and sense before you find out the result of your culture and sensitivity. And it is then mandatory that you proceed with specific antimicrobial treatment based on the result of the culture and sensitivity. You cannot do the culture and sensitivity after you start empirical. You get wrong results, huh? So you start empirical, you do culture and sensitivity, and then you start empirical antibiotic treatment. Now, your treatment is basically mechanical debridement, whichever way you're going to look at it, to eliminate all the granulation tissue. And then you do conservative surgical treatment, which could be subgingival curettage, or compare it with open flap surgery, which is very invasive. But I don't waste time. I just open up and I do flap surgery. And then, of course, bone regeneration with or without GTR. Now, in your management, you should also be able to describe the various modalities for GTR, including the Ogunsalu sandwich technique. And finally, extraction of the implant and reimplantation with bone grafting is also a modality of treatment which most standard textbook of implantology fails to describe or mention these days. Now, systematic approach for prevention and treatment of periimplantitis was suggested by Lang. This was termed as the cumulative interceptive supportive therapy, CIST. Now, this includes mechanical debridement with subgingival curettage, local antiseptic or antimicrobial chemotherapy, systemic antibiotic chemotherapy, and surgical treatment. And according to the CIST protocol, perimplantitis lesion with bone loss of 2 millimeters, the initial treatment should be mechanical debridement with or without antimicrobial treatment. And let me tell you, I am not patient. When I see 2 millimeters, even 1.5 millimeters, I want to open up, I want to clean out, place implant, start the patient with antibiotics. And I do culture and sensitivity. Because, I can't wait. I can't wait. I just do it. So you can follow the CIST, you will still be right. Or you can follow me. Non-surgical mechanical debridement with 2% chlorhexidine can also be considered. Surgical intervention is considered if bone loss is 2 millimeters and the pocket formation is greater than 5 millimeters around the implant. I mean, by the time I am seeing that amount of bone loss, I'm not really happy. So these are references that you can read relating to the topic, and I think that is a very important presentation for you for your essay.